on who is fit, indication, patient selection by Dr. Nimmy RAJ.
Good morning, everyone. I'll be talking on who is a fit patient for a lenticule extraction procedure. I have no financial interest in whatever machine being told in this presentation. So the keratorefractive lenticule extraction surgeries are the upcoming or most newest technology of refractive surgery in which a small incision is made and a lenticule is removed from the cornea to correct the refractive error. It is currently approved for myopia and myopic astigmatism, and many studies show that it has a safety, efficacy, predictability and outcomes which is comparable to LASIK, which is a refractive surgery which has been there for the past 30 to 40 years. And even in spite of having a steep learning curve, this surgery has gained global popularity because of the long-term stability of cornea that the surgery provides. There are various platforms. The only FDA approved ones are Smile and Smile Pro. Smile was approved in 2016, but surgeries were being done from early 2008 itself. And after many studies, it got approved finally in 2016. But the problem was that it didn't have tracking systems or cyclotorsion correction parameters or softwares in it. The Zeiss came with a updated version, Smile Pro, in 2022. It came and it got FDA approved in 2024 with softwares for cyclotorsion and also a faster the laser pulse repetition is at faster rate so that the lenticule is cut within a dramatic time of less than 10 seconds. Smile is approved for treatment of power -1 to -10 diopters. Lesser myopia like less than -1, it's not approved. And also it is FDA approved for -3 diopter cylinder. Recently in an updation in 2018, initial approval in 2016 was only for spherical correction, or the astigmatism correction was allowed only up to 0.5 diopter. But in an pre-market approval, FDA has approved for cylindrical correction up to 3 diopters in 2018. Now newer platforms have come. Clear, SmartSight, Silk are examples. These are approved not by FDA, but the European Conformity has approved these and have regulatory approval to use in Asia and in Asia and Europe. They are approved to be used. These newer machines have centration and cyclotorsion correction features, and the initial results show that they are promising machines for future with comparable results to that of Smile. So for any refractive procedure, the age of the patient should be more than 18 years at least. FDA approved for lenticule extraction procedures is 22 years. Clearly suggests a stable refractive error to be documented. That is, there should not be a major change in spherical or cylindrical power during the past year. The equivalent change should be less than 0.5 diopters. The patient you select should be off contact lens. For soft contact lens, it's 2 weeks, and rigid contact lens, it's 4 weeks. Free of any ocular pathology and adequately counseled, and patient having realistic expectation is of utmost importance. Contraindications, as in any other procedure: unstable refraction, abnormalities of the cornea, if the corneal thickness is insufficient, if there is any other problem like visually significant cataract, uncontrolled glaucoma, any other external disease which needs to be controlled before the procedure like blepharitis, dry eye, atopy, allergy, which has to be taken care of. Autoimmune diseases, if present, is a contraindication. Pregnancy, lactation is a contraindication. And if your patient has unrealistic expectations, that patient is not suitable for a lenticule extraction procedure. Especially patients with excessive anxiety, depression are prone to have more suction loss also during the procedure and are a relative contraindication for the procedure. In preoperative assessment, you will document the use uncorrected visual acuity, best corrected visual acuity, IOP. In refraction, you have to look for both the refraction current and past refraction. If any document available, that has to be cross-checked. Stability for ascertaining the stability. astigmatism has to be taken care of, especially as we are going for a lenticule procedure. Obtain manifest and cycloplegic refraction, and if there is any disparity of more than one diopter, that also requires a re-evaluation. In clinical examination, before going ahead with a lenticule procedure, prominent frontal ridge, external appearance of the patient also has an importance, especially if the surgeon is a new surgeon. Prominent frontal ridge, prominent nose, deep set eyes, that might lead, have suction loss, increased chance of suction loss, that has to be told to the patient prior itself. Also assess for any squint, any lid closure abnormalities like lag of ophthalmos. Look for dry eye blepharitis. In cornea, look for any scars, vessels, signs of inflammation, any subclinical dystrophy features. If you are seeing, those patients are not suitable for lenticular extraction. While examining in the slit lamp itself, if you can make out a large angle kappa with the slit lamp light itself, that also is a sign that you have to counsel the patient prior with regard to the expectations in the post-op. Look for any cataract, fundus detailed evaluation as in any other refractive surgery is required. Detailed investigations including keratometry, cornea topography, pachymetry, pupillometry can be done. Dry eye evaluation is also advisable. Any patient with the refractive error as -1 to 10 diopter, -0.75 to -3 diopter cylinder is FDA approved for undergoing SMILE. The normal values for RSBT, residual stromal bed thickness, is 250 microns. Percentage tissue alteration, that is the lenticule thickness plus cap cut divided by CCT, should be less than. You should not alter more than 40% of the total thickness of cornea. Lesser CCT, like 475, is a the patient below that is not suitable for the procedure. Also, a mesopic pupil size more than 7 mm, the side effects or the symptoms post-surgery like glare and all will be more, so that also has to be taken care of. Any abnormal topography pattern, any foam thrust, even minor changes in the topographic pattern, the patient is not suitable for refractive surgery or lenticular extraction. Who will benefit? Patients with pre-existing dry eye, definitely, because as the incision made is larger in LASIK and more of basal nerve plexus is cut, patients with pre-existing dry eye disease is going to definitely benefit from a SMILE procedure. Nowadays, even with 2 mm, 2 to 2.5 mm small incision itself, lenticule can be extracted. So in patients with dry eye disease, SMILE is an excellent choice. There are many studies which show that immediate post-op period, definitely SMILE has an advantage, but over long term, both the procedures tends to have similar incidence of dry eye. But for that initial comfort and all, SMILE is the better option. Engaged patients, people engaged in contact sports are likely to have flap-related complications with LASIK. So the absence of flap and also maintaining corneal strength as lesser fibers are cut is an advantage for SMILE. Patients with thin corneas, even though the most preferred procedure is PRK, prefer keratorefractive lenticular extraction procedures over LASIK. So least preferred will be LASIK in those patients, as there can be chances of ectasia post-operatively. In higher refractive error patients, few studies, even though it is not FDA approved for more than 10 diopter power, a few studies have shown that if for a more than -10 diopter power, if the thickness permits, Kellex surgeries will be better than LASIK. In patients with larger mesopic pupil size also, when compared to LASIK, the postoperative complaints like ghost images, glare, etc. will be less with SMILE. Patients who will not benefit will be patients with hyperopia, because there are no platforms that is giving us results with hyperopia. But LASIK and PRK, we have options for hyperopia correction also. For corneal diseases, epithelial lesions and all, PRK is a preferred procedure. Higher astigmatism, FDA approved LASIK parameters is -6 diopter. And also if there is irregular astigmatism, higher order aberrations, wavefront guided, topo guided treatments are available only currently in LASIK and PRK platforms. In low myopia, complicated orbital anatomy, etc., if the surgeon is less experienced, there are chances of retained lenticule as the lenticule thickness will be less, and also chances of suction loss is more. That cases we have to be cautious. In patients with significant preoperative anxiety also we have to be cautious. And regarding visual recovery in KLX, the variability of visual recovery is a problem. So hitting the sweet spot with respect to energy parameters in your particular machine can be the key factor in achieving best visual acuity postoperatively. Then another limitation is the lack of enhancement options. You cannot do a repeat smile in a patient whom you have done a smile procedure already. So you have to go on to do a PRK or a lesser flap thickness LASIK in those cases. And as I said, the customized options or wavefront topo-guided options are less established with SMILE. All these procedures are comparable in efficacy, safety, and predictability. And what you will select depends on many criteria. Patient selection is of utmost importance. Meticulous evaluation, detailed evaluation with all the investigative modalities available is important. A thorough understanding of patient's need and tailor down the options. Clinical scenarios have to be assessed them. Decide a patient. You must choose, but always choose wisely.